You're lying in bed. It's 11:30 at night. You had dinner maybe 2 hours ago. Nothing crazy, just some pasta, a bit of tomato sauce, maybe a glass of red wine because it was Friday and you earned it. And now there's this sensation right behind your breastbone. Not pain exactly, more like a slow, hot pressure, like someone lit a match inside your chest and just left it there. You shift to your left side. Doesn't help. You prop yourself up on a second pillow. Maybe that takes the edge off for a minute. You think about getting up and finding the antacids, but you're tired. And honestly, you've done this so many times that the whole ritual feels like brushing your teeth, just something you do before sleep now. Here's the thing that stops me cold when I hear this from patients. Not the heartburn itself, the word now. As in, this is just part of my life now. That sentence is a surrender. And what you're surrendering to is not what you think, because I need to tell you something that might genuinely surprise you. In the majority of chronic heartburn cases I've seen, and I've seen hundreds over 17 years, the problem is not too much acid. Let me say that again. Your stomach is probably not making too much acid. In fact, for a significant number of people over 50, the opposite is true. You may actually be producing too little. And that single misunderstanding, that one wrong assumption, is the reason millions of people stay stuck on medications that were never designed to be taken for years, treating a problem that keeps coming back because they're treating the wrong thing. Now, before I go any further, I want to be upfront with you. I'm a general practitioner. I'm not your doctor. What I'm going to walk you through today is based on published clinical evidence and 17 years of seeing real patients, but none of it replaces a proper evaluation by someone who knows your specific history. If something I describe sounds like you, that's a reason to bring it up at your next appointment, not a reason to skip it. Fair enough? Good. Let's keep going. Hit subscribe right now and tap the like button. We're building toward 300,000 subscribers on this channel, and every single person who joins makes it possible for me to keep doing this. Sitting here, telling you the stuff that doesn't fit into a 7-minute office visit. Because what I'm about to explain is the kind of thing you will almost never hear in a standard consultation. Not because your doctor doesn't know it, because they literally don't have the time. So let's use ours. And here's where it gets interesting. Your stomach is essentially a biological acid chamber. That's its job. It's supposed to be acidic. We're talking a pH somewhere between 1.5 and 3.5. That's roughly the same acidity as battery acid, just to give you a sense of scale. And that level of acidity isn't a design flaw. It's the whole point. That acid does 3 critical things. First, it breaks down protein. Without sufficient acid, the steak you had for dinner doesn't get dismantled properly. It just sits there, fermenting. Second, it kills bacteria. Your mouth is full of microorganisms, so is your food. Stomach acid is the security checkpoint. And third, and this is the one nobody talks about, it triggers the valve at the top of your stomach to close. That valve has a name. It's called the lower esophageal sphincter. Think of it like a trap door at the bottom of a chute. When the acid level in your stomach reaches the right concentration, it sends a chemical signal that tells that trap door to shut tight, sealed. Nothing gets back up. But here's what happens when acid production drops. And it does drop naturally as you age. By 60, many people are producing roughly 40% less stomach acid than they did at 30. That's not a disease. That's just biology. Your parietal cells, the little factories in your stomach lining that manufacture hydrochloric acid, they slow down. They get tired. Some of them retire altogether. So now you've got a stomach that's not acidic enough. The trapdoor doesn't get the signal to close properly. And the small amount of acid you do have, which is still acid, still irritating, starts creeping upward into your esophagus, which has zero protection against it. Your stomach has a thick mucus lining built to handle acid. Your esophagus does not. It's like the difference between pouring lemon juice on a tile floor versus pouring it on a paper towel. Same liquid, completely different result. And what do you feel? Burning. That familiar, miserable, middle-of-the-night burning. So you reach for the antacid. Or your doctor puts you on a proton pump inhibitor, a PPI, which is a medication specifically designed to reduce acid production even further. And for a few days, maybe a few weeks, you feel better, because less acid means less irritation in the short term. But you've just made the underlying problem worse. You've turned down the volume on a factory that was already underproducing. The trapdoor gets even less signal to close. The cycle deepens. And 6 weeks later, the heartburn is back, and now you need a higher dose. Does that sound like a cure to you? Or does that sound like a subscription? I want to be very clear. PPIs are legitimately life-saving medications for specific conditions. Erosive esophagitis, Zollinger-Ellison syndrome, short-term treatment of confirmed ulcers. I am not telling you to throw your medication away. What I am telling you is that these drugs were originally approved for 4 to 8 weeks of use, not 4 to 8 years. And yet the data shows that a staggering number of people over 50 have been on them continuously for far longer than that, sometimes decades. And the downstream effects of chronically suppressed stomach acid are not trivial. Let me walk you through just 3 of them because I think you deserve to know what nobody puts on the label in bold print. Number 1, mineral absorption. Your body needs stomach acid to absorb calcium, magnesium, and iron from food. When you suppress acid for years, you are quietly starving your bones of calcium. There is published data, peer-reviewed in major journals, showing a measurable increase in hip fracture risk in long-term PPI users over the age of 50. We're not talking about a tiny bump. Some studies suggest a 20 to 35% increase in fracture risk after 5 or more years of daily use. That is not a footnote. That is a structural risk to your skeleton. Number 2, gut bacteria. Remember how I said stomach acid kills incoming bacteria? When you lower that acid, you're essentially leaving the front door of your digestive system unlocked. One of the most well-documented consequences is an increased risk of a bacterium called C. difficile, a nasty gut infection that causes severe diarrhea, can lead to hospitalization, and in older adults can be genuinely dangerous. The connection between long-term PPI use and C. diff infection is so well established that it's now listed in clinical guidelines as a recognized risk factor. And number 3, kidney function. This one still doesn't get enough attention. There's a growing body of evidence linking prolonged PPI use to chronic kidney disease. Not acute damage. Slow, silent, progressive decline in kidney function that you wouldn't notice until it shows up on a blood test years later. A large observational study published in a leading nephrology journal followed over 10,000 patients and found that those on PPIs for more than 2 years had a statistically significant increase in the risk of developing chronic kidney disease compared to non-users. That's not something I can ignore, and neither should you. And here's the part that actually gives me hope. Because I refuse to leave you sitting in the problem without showing you the way out. Most of what I just described is modifiable. If the root issue is low acid production and a lazy valve, then the strategy isn't to suppress acid further. The strategy is to support your stomach's natural function, protect your esophagus mechanically, and address the habits that are making everything worse. And almost all of it can be done with things you already have in your kitchen. But before I get to the protocol, let me tell you about someone. I'll call him George, 61 years old, retired electrician. Came into my office about 4 years ago, looking like a man who hadn't slept properly in months. Because he hadn't. George had been dealing with heartburn for over 8 years. 8 years. He'd been on omeprazole the entire time. Started at 20 milligrams, moved up to 40. His previous doctor had renewed the prescription every year without much discussion. George assumed that was just how things worked. You get older, you get heartburn, you take a pill. End of story. But it wasn't the end of the story. George also had constant bloating after meals. He told me, and I remember his exact words, "Doc, I feel like my food just sits there. Like my stomach forgot what to do." He also had cracking at the corners of his mouth, which he thought was just dry skin. And his energy had been dropping steadily for 2 years. He chalked it up to age. When I ran his blood work, his magnesium was low. His B12 was borderline deficient. His iron was headed south. All 3 of those are nutrients that require adequate stomach acid for proper absorption. I looked at George and said, "I think your heartburn medication might be part of the problem. He stared at me like I'd told him water wasn't wet. We didn't just stop his PPI cold. You should never do that abruptly because there's a well-documented rebound effect where your stomach temporarily overproduces acid when you withdraw the drug suddenly. Instead, we tapered him slowly over 6 weeks while simultaneously introducing the exact protocol I'm about to share with you. Within 3 months, George's bloating was gone. His energy was noticeably better. His B12 came back up. And his heartburn, the thing that had been running his nights for nearly a decade, went from nightly to maybe once or twice a month, and mild enough that he didn't need medication for it. George told me something at his follow-up that stuck with me. He said, "I spent 8 years treating the smoke detector instead of the fire." And honestly, I've never heard it put better than that. Now, let me give you exactly what I gave George, step by step, week by week. This is the practical protocol. Everything here is cheap, accessible, and grounded in physiology. No expensive supplements, no special equipment. Just your kitchen, your habits, and your willingness to actually try something different for 30 days. Let me start with what I call the morning warm lemon reset. Here's why this works. Lemon juice is naturally acidic. Its pH sits around 2. When you drink diluted warm lemon juice on an empty stomach, you're gently introducing acidity into a system that may be underproducing its own. You're essentially priming the pump. It's like warming up an engine before you drive in winter. You're not adding fuel, you're just getting the machinery ready to do its job. Here's exactly how to do it. Squeeze half a fresh lemon, not bottled concentrate, fresh, into roughly 200 milliliters of warm water. Not hot, not cold, warm. Around 40 degrees Celsius, which is comfortable to sip without burning your mouth. Drink it 20 to 30 minutes before breakfast. Every morning, consistently. This is not a one-time thing. This is a daily reset. One caution. If you currently have an active ulcer or diagnosed erosive esophagitis, skip this step and talk to your doctor first. The acidity could aggravate an existing wound. For everyone else, this is one of the cheapest, simplest interventions that exists, and a bag of lemons costs practically nothing. Actually, I want to pause here for a second. Drop your age in the comments. Just a number. I'm not asking because I'm nosy. I'm asking because your age literally changes the recommendations I should be making. The protocol for someone who's 52 is different from someone who's 68. The more I understand who's actually watching, the more precisely I can calibrate these videos to match your specific biology. So, your age. That's it. Takes 1 second. All right, back to the protocol. The second method I call the apple cider vinegar bridge. Now I know, apple cider vinegar has been talked to death on the internet, and half of what you've read about it is exaggerated nonsense. But the basic mechanism here is sound, and it's the same principle as the lemon. You're introducing mild acidity to support a stomach that isn't making enough of its own. Here's the exact protocol. 1 tablespoon, 15 milliliters, of raw, unfiltered apple cider vinegar in a full glass of water, about 250 milliliters. Drink it 5 to 10 minutes before your 2 largest meals of the day. That's it. Not straight, not undiluted, always in water. Undiluted vinegar can damage your tooth enamel and irritate your throat. Don't do that. Why before meals? Because you're setting the stage. You're pre-acidifying the stomach so that when food arrives, the digestive process kicks in properly from the start. Protein gets broken down, the valve gets the signal to close, food moves through instead of sitting and fermenting. A bottle of apple cider vinegar costs a few dollars and lasts weeks. If this isn't accessible to you, the lemon alone will do the job, just slightly more slowly. Now, the third method. This one is mechanical, not chemical, and it's embarrassingly simple. I call it the gravity protocol. Your esophagus runs downward into your stomach. When you lie flat after eating, you're taking gravity out of the equation. You're essentially turning a one-way chute into a flat surface that acid can slide back up. This is why heartburn is almost always worse at night. It's not because your body makes more acid at night, it's because you're horizontal. Here's the fix. Do not eat anything within 3 hours of going to bed. 3 hours minimum. And when you do go to bed, elevate the head of your mattress by 15 to 20 centimeters. Not with extra pillows. That just bends your neck and can actually make things worse by compressing your abdomen. Raise the actual head of the bed. You can put wooden blocks or sturdy risers under the two legs at the head of the bed frame. Or you can buy a foam wedge that goes under your mattress. Either way, you're creating a gentle downward slope from your esophagus to your stomach, and gravity does the rest. This alone, just this one change, resolves nighttime heartburn in a remarkable number of my patients. No pills, no supplements, just physics. Method 4. The slow chew reset. This one sounds almost insultingly simple, but hear me out because the physiology behind it is real. Digestion doesn't start in your stomach, it starts in your mouth. When you chew food thoroughly, you're doing two things. First, you're mechanically breaking it into smaller particles, which means your stomach has less work to do. Second, and this is the important part, chewing stimulates saliva production, and saliva contains an enzyme called amylase that begins breaking down starches before they even reach your stomach. It also contains bicarbonate, which is mildly alkaline and helps buffer acid in the esophagus. Most people over 50 chew each bite somewhere between 5 and 10 times and swallow. That's not chewing, that's loading. The target is 25 to 30 chews per bite. I know that sounds tedious. It is tedious, for about 3 days. After that, it becomes automatic, and you'll notice that your post-meal bloating drops dramatically. You may also notice that you eat less, because proper chewing gives your satiety hormones time to actually register. Cost of this intervention? 0. You already own the equipment. You've had it your whole life. Method 5, what I call the bitter boost. This one comes from a tradition that modern medicine mostly forgot, but your grandparents probably knew instinctively. Bitter foods stimulate acid production. That's a direct physiological response. When bitter compounds hit the receptors on your tongue, they trigger a nerve signal that tells your stomach to start producing hydrochloric acid. It's like ringing the dinner bell before the food arrives. Here's how to use this. Eat a small salad of bitter greens, arugula, endive, dandelion greens, radicchio, about 10 to 15 minutes before your main meal. You don't need a huge portion. A handful is enough. The goal isn't nutrition from the greens themselves, it's the signaling effect. You're waking up your digestive system before you ask it to work. If you hate salad, you can steep fresh ginger root in hot water, about a 2-centimeter piece sliced thin in 200 milliliters of hot water, and drink it as a tea before meals. Ginger has been shown in clinical research to accelerate gastric motility, meaning it helps your stomach empty faster, which means food spends less time sitting there generating pressure and reflux. A bunch of arugula costs next to nothing. Fresh ginger root is equally cheap, and both have been used for digestive support for literally centuries, long before the pharmaceutical industry existed. Now let me walk you through how to implement all of this without feeling overwhelmed, because I know that 5 methods at once sounds like a lot. Week 1 is what I call the foundation week. You're making only 2 changes. First, start the morning warm lemon water, every day, 20 to 30 minutes before breakfast. Second, implement the 3-hour dinner-to-bed gap. No eating after 8 p.m. if you go to bed at 11. Adjust accordingly. That's it for week 1, just those 2. Let your body begin to recalibrate. Week 2, you add the apple cider vinegar before your 2 biggest meals. And you begin consciously working on the chewing, 25 to 30 chews per bite. You'll forget constantly at first. That's fine. Every time you catch yourself speed eating, slow down. This is a practice, not a test. Week 3, you add the bitter greens or ginger tea before at least 1 meal a day. And this is also the week where you elevate the head of your bed if you haven't already. By week 3, you should already be noticing a difference in how you feel after meals. Less pressure, less bloating, fewer episodes of that creeping nighttime burn. Week 4 and beyond is consolidation. By now, the protocol should feel like routine, not effort. This is when you start paying attention to your personal triggers, because heartburn triggers are not universal. For some people, it's tomatoes. For others, it's chocolate or peppermint, both of which relax the lower esophageal sphincter. For many, it's simply eating too fast or too much in one sitting. Keep a simple log for 1 week: what you ate, when you ate it, and whether you had symptoms that night. Patterns will emerge fast, and they'll be specific to you. I also want to address something that almost nobody brings up in these conversations: stress. Chronic psychological stress directly affects your gut. It does this through the vagus nerve, which is the main communication highway between your brain and your digestive system. When you're chronically stressed, vagal tone decreases and your stomach motility slows down. Food sits longer, pressure builds. The valve gets lazy. It's not in your head, it's in your nervous system, and the effect on digestion is measurable. One of the most effective things you can do, and this will sound almost too simple, is practice slow, deep, diaphragmatic breathing for 5 minutes before your main meal. Inhale through your nose for 4 seconds. Hold for 4 seconds. Exhale through your mouth for 6 seconds. Repeat. This directly stimulates the vagus nerve, shifts your nervous system from fight or flight into rest and digest mode, and measurably improves gastric motility. 5 minutes. Before dinner. Every day. I had a patient, Margaret, 67, who added nothing else to her routine except this breathing practice before dinner and elevating her bed. Nothing else. And her nighttime reflux episodes dropped by roughly 60% within 2 weeks. 60%. From breathing and gravity. That's not a miracle. That's just your body doing what it was designed to do when you stop getting in its way. Let me also talk briefly about something that might apply to you directly. If you've been on a PPI for more than 8 weeks, and especially if you've been on one for years, please do not stop it abruptly. I cannot stress this enough. There is a well-documented phenomenon called rebound acid hypersecretion. When you suppress acid production for a long time and then suddenly stop, your stomach overcompensates. It floods the system with acid, often more than it was producing before you started the medication. This can create a brutal flare of symptoms that convinces you the medication was the only thing keeping you alive, which drives you right back to the prescription. It's a trap, and it's entirely avoidable if you taper correctly. Talk to your doctor about a gradual step down. A common approach is to reduce the dose by half for 2 weeks, then switch to every other day for another 2 weeks, then stop. During this taper, the protocol I just described can help fill the gap. But this is absolutely a conversation to have with your physician. I'm giving you the framework. They give you the personalized plan. All right, let me pull everything together for you now. This is your cheat sheet. If you screenshot anything from this video, screenshot this. Check mark. Warm lemon water every morning, 20 to 30 minutes before breakfast. Half a lemon in 200 milliliters of warm water. Check mark. Apple cider vinegar before your 2 main meals. 1 tablespoon in a full glass of water, 5 to 10 minutes before eating. Check mark. Stop eating 3 hours before bed. Non-negotiable. Check mark. Elevate the head of your bed by 15 to 20 centimeters. Blocks or a wedge, not pillows. Check mark. Chew every bite 25 to 30 times. Slow down. Check mark. Add bitter greens or ginger tea before at least 1 meal daily. Check mark. 5 minutes of slow diaphragmatic breathing before dinner. 4 seconds in, 4 hold, 6 out. Check mark. Track your personal food triggers for 1 week. Write it down. Simple log. And here are your red flags. The moments when you stop self-managing and you call your doctor. If you experience difficulty swallowing, food feels like it's getting stuck, that needs investigation. If you have unexplained weight loss along with digestive symptoms, that needs investigation. If you see blood in your stool or vomit, that is an emergency. Full stop. If your heartburn suddenly gets significantly worse after being stable for years, that's a change worth evaluating. And if you're over 50 and you've had reflux symptoms for more than 5 years without ever having an endoscopy, ask your doctor whether one is appropriate. There's a condition called Barrett's esophagus where chronic acid exposure changes the lining of your esophagus. And while it's manageable, it does need to be monitored. Everything I've walked you through today is designed to support your body's own digestive function. It is not a substitute for clinical evaluation when something genuinely needs to be examined by a professional who can look, test, and diagnose. Use this as a foundation. Use your doctor as a partner, Those two things are not in competition. Now, let me leave you with this. Nobody in a white coat is going to sit with you for 25 minutes and explain the difference between too much acid and too little acid. Not because they don't know, because the system wasn't designed to deliver that conversation. A standard office visit is built around a complaint, a prescription, and a follow-up in 6 months. That's not cynicism. That's just the economic architecture of modern healthcare. Doctors are good people trapped in a bad structure. And that's exactly why this channel exists, to fill the gap between what your doctor knows and what your doctor has time to tell you. If this helped you, subscribe. Hit the like button. It sounds small, but it directly determines how many people see this video. And here's what I'm actually going to ask you to do. Send this to one person, not 10, one. The person in your life who's been popping antacids every night for years and has just accepted it as normal. The person who's been treating the smoke detector instead of the fire. Send it to them. Because sometimes the thing that changes someone's health isn't a new doctor or a new drug. It's just a piece of information they never had before. I'm Tilden. I'll see you in the next one.